Hey people, how you going? Here we are, 8 o'clock once again, our weekly little visit into the world of soft tissue therapy. My name is Matt Phillips. I am your host for the Sports Therapy Association videocast and podcast, and also the creator of runchatlive.com. Calm. So really excited if you have kept up with this month, 5 Tuesdays in this month. So we are having 5 guests from the world of CPD, which is happening either in March or April in the UK. And before we bring up the finale, I think I'll refer to him as, we've put him, I said he's got to come at the end because it really is the cherry on the cake, as he's often referred to. Jack March is going to be with us shortly. But before I do that, obviously I'm going to have to just let you know, he liked that, he's smiling away, the cherry on the cake. How did we start off way back at the beginning of the month? We had Mike Grice and Daniel Williams talking about dermoneuromodulation, which I appreciate is a mouthful, and I almost feel guilty talking about it with my students and learners, because it sounds like it's a name that's, I mean, no offense to Diane Jacobs, but she created it 20 years ago. So at the time, it wasn't cool to come up with long names. It wasn't a marketing thing. She just thought, well, that's exactly what's happening, dermoneuromodulation. But these days, it sounds like some catchy name, but it's not. It really is, I think, as we described in the show, it's essentially the best idea that we've got of the mechanism of action of what we're doing when we touch people and the effect we're having on the nervous system with the skin. It's a fantastic testimony to the great mind of Diane Jacobs, kind of 25 years later after she came up with it, after kind of working with the likes of Lorna Mosley and David Butler and that. And it's something that sadly this month in March, it's over. It's been in Birmingham, it's been in Exeter, but there is still the June level 2, which is for people who've already got an idea what it is. And you can still book onto that by getting in touch with Mike Grice or going to Movement Therapy Education on Google. You've got June in Birmingham, and then the weekend, June the 10th, so the week after June the 4th, you've got 3 days in Exeter with James Morgan of Barefoot Physio. What do we have afterwards? The week after that, Jack, if you're down there in the lobby, you may as well have a cup of tea, mate. It's going to take a little bit of time. But we had Pete Malliaris, absolute, I don't like to say a guru, absolute giant in the name of tendinopathy and research, and has been around forever. One of the people definitely who I started improving my knowledge of tendinopathy with, and he came with us and talked about his courses, which unfortunately again are over. You missed it. But if you go to his website, tendinopathy.rehab.com, and subscribe, okay, you've missed the courses this time around, but there's so much information there. You got blogs, podcasts, so much free CPD, and if you sign up, you'll get news of when he's coming back to the UK. So yeah, that was a great episode, and all of these episodes I'm talking about obviously are available on all podcast apps to download and listen to in the pleasure of your own time. Or if you like watching video, you can go to YouTube, the Sports Therapy Association YouTube channel, and you can watch the video there. Or you can go to thesta.co.uk and you can see all the show notes and everything there as well. The week after, we talked to the wonderful Greg Lehman, who was here talking about reconciling biomechanics with pain science, which is a course which I hosted way back when, 2000 and whenever it was, years ago in Brighton. And since it's just, well, I can't remember now. It's been in something like 5 continents and I don't know how many different countries, 50 countries, and translated into I don't know how many languages, but an amazing course, which I'm obviously biased, but it really ticks my boxes of just helping therapists not either say it's all about pain science, it's all about the biomechanics. It's just showing how the two obviously fit together, and you can't separate them, because in human beings, you can't separate the bio from the psycho and the social and all that sort of stuff. It's what we are. So really nice bloke. Great source of information. And again, if you can't make it over to Cork in Ireland on April the 2nd and 3rd, which is when his course in the UK is, then there's so much information at greglehman.ca, the website, so much free stuff on YouTube. And if you like a little bit of comedy injected into your learning, then that's probably a great way to go. We then had last week Angela Jackson, which again was just amazing chat. It was really nice for me because, like the guest tonight, Jack, I know pretty much back to front, and I know I'm not going to get any surprises. But I'm just bringing him here for you. But Angie is someone new who I've never talked to before, so that really was really great fun for me, and it just reminded me how thrilling it is and how important it is to meet people who you haven't talked to before. I'm joking about Jack. Jack is an absolute source of inspiration for me and the whole Physio Matters podcast team and everything they put together in Choose Health. Help kind of forge my way forwards and where I wanted to go. So But yeah, Angie was a lovely breath of fresh air, and the information she gave with regards to how to work with the younger population, some real clinical pearls, as Jack Chu would say, and an episode which I would catch up with if you are treating younger children, young adults, because it's something which are just not on our courses. It's the same kind of thing as, you know, thinking that women are little men. It's not true. It's a totally different population in lots of respects. And the same thing goes for kids. They're not little adults. And just because you can treat a 6-foot person doesn't mean you can automatically just size it down into a 3-foot person. Doesn't work that way. So check that out. Right. That was, and you'd think that would be enough. I mean, I was thinking today when I was going for a run, what other show gives you kind of 4 fantastic speakers like that in month, weekly? It's just ridiculous. In fact, I think it's too much personally. I'm going to have to talk to Gary because it's just not doing these guests any favors. It's so much information. And on top of that, we're now having a 5th guest, which, like I said, is just the finale, which is just going to be the cherry on the cake, who's going to come up very shortly. So like I say, all those episodes are available on your favorite podcast app or on YouTube. And if you want to join us live, then it's 8 o'clock on Tuesdays. Every week. We've done it for 94 times now. This will be people already in the house as I've been talking away. Glenn Murphy is with us. When you do come and join us live, then I can bring whatever comments or questions you've got up onto the screen. So you can't see this on the podcast, but Glenn Murphy just come up with his logo there. Brian Huxley is here. Thanks for joining us. Phil Griffiths is here. Catherine Reimer is here. Happy birthday, Catherine. Hope you're very well. Who else? Got Andy Glover. There's a lot of people in here, Jack. I don't want to scare you, but seem to have turned up expecting quite a lot. Daniel Williams, who was our guest on the first week, is here as well. Hey, Danny, how you doing? On 140 runs in 140 days or something. If not following Daniel, make sure you are. Leslie Campbell, hope you've had a glass of fizz in your hand, Catherine. Leslie Campbell's lovely. You should follow Leslie for pure, just feel good value. And Gary Benson, founder of the Sports Therapy Association, is here as well. And also Liz Bailey Physio has joined us. Jack, you're pulling in the A team today. Liz is with us as well. Great guests recently, Matt. I know, Liz. I mean, it was, you were, I don't know how long ago you were now, but you set a benchmark and I've managed to stay close to it. So thanks for joining us, Liz. Looking forward to hear some questions for you from Jack. Yeah, you know what I mean. So there we go. Right. We've had enough chat now. Thanks for joining us if you're listening to the podcast. So without further ado, I should bring up the man of the hour, who is Mr. Jack March. Hey, mate, how you doing?
Yeah, I'm good, thank you. That was lots of very nice compliments in your introduction.
Well, I'm a big fan of yours, mate. We've go back quite a long way, I think, and you were part of Run Chat Live from the very beginning, along with Jack and the Physio Matters podcast team.
I remember insulting you a long time ago. Do you remember that?
I was going to bring that up. Oh, no, you voted. You did vote, yeah, out of 100 and I don't know how many episodes, you voted my and Tom Goom's episode as your least favourite.
Yeah, a slight exaggeration. I think it was about 15 at the time, but yeah.
No, I think you'll find you into the hundreds and you put us at the bottom.
Is that right?
But that's okay. That's cool. That's okay. I like you because you're honest. It's a good trait. So I just wanted to say, well, before we start talking about rheumatology, looking forward to I just saw it on LinkedIn today, the 24-hour podcast with Jack Chu. For those of you who don't know, Jack Chu is kind of like the creator of Chu's Health and also the Physio Matters podcast. And Jack is kind of his right-hand man. Behind every Jack, there's a Jack March, and you're the guy who holds it all together. So one of your recent things is this 24-hour podcast. Tell me a little bit about that. What's the idea behind it? When's it happening?
Yeah, so that will start on this Saturday, 3 p.m. our time, England time, and it will go 3 p.m. on Sunday, and Jack will be live for the entire 24 hours. Yeah, I know. So we have done 99 monthly episodes of the Physio Matters podcast, and we basically decided we should probably stop at some point, and we're going to finish on this 24-hour insane podcast. We want to be mad, so we're going to be mad. We're going to raise money for freehab.co.uk, which is a social enterprise who provide rehab to people for free. So it's supported by charity funding. So we're going to raise money for that. There's 2 ways to do it: direct donation and also buying raffle tickets for courses. So it's like £20 for a raffle ticket. And you mentioned some courses and stuff, but one of my courses is on there, and Eric Meara and Joe Gibson, to mention some. I try not to remember. But yeah, it's really good. It should be really funny. We've got an absolute ton of our past guests coming on. So every half an hour for the entire 24 hours, even through the middle of the night, we've got, what could possibly go wrong, Becky? Yeah, a lot is the answer to that question. So yeah, a new guest every 30 minutes. I think Liz is going to be on. I think Liz is coming. Liz, who's in the chat. Every half an hour, we'll have a new guest to speak to and all sorts of things. We've also got some challenges for Jack to do whilst he's staying awake for 24 hours and talking. So yeah, it should be really good.
Amazing. Yeah, it's like every £100 that you raise for free hab is like Jack's got a little envelope or something. He's got to open it up and do like
a challenge. Yeah,
amazing. Because if you don't know Jack Chew, he really is kind of famous for being the mouth of the North, Manc lad. So gift of the gab. He's kind of like, if you remember the word with Terry Christian, Terry, it's kind of like took over from Terry Christian, but rather than music, it was about kind of like physiotherapy, but also a real leader in recognizing and helping the breaking down of barriers between professions. And although it started off as the physiotherapy or the Physio Matters podcast, it soon became apparent, probably one of the first people who started realizing, hold on, why are we going to talk to physios? Healthcare isn't just physios. And you started having people from all different, including myself, which was nice. Still probably the only sports therapist that's been on the show and the last one. So I don't know what that meant. But yeah, so that's this Saturday. And I'm actually number 2. I'm after Elaine Miller. So that's going to be tricky. I'm just trying to think how we can wreck Jack within the first 5 between kind of 3 o'clock and onwards. I've got a few ideas. Anyway, great idea, mate. As always, setting the barrier, setting the new kind of like threshold for entertainment and education. So, Liz is here as well. Yeah, Liz says, hey, I'm chatting with Chew at 11 p.m. Oh, wow, you're doing the late shift, are you, Liz? Fantastic. That'll keep his eyes open. Fantastic. That's a good idea, actually, putting some Liz Bailey in at 11 o'clock. That'll give him kind of a second wind. You're good at giving people second wind. I don't even know what that means. Right. Okay. Enough of this. We are now going to talk about rheumatology. Now, you were a guest back 50 weeks ago, I think 51 weeks ago, with kind of a Rheumatology 101. And I'm hoping that in 50 weeks, people have either forgotten some of the things you said, or in the kind of couple of thousand people. Thanks everyone who downloaded the podcast. Actually, we've had a kind of a bit of a burst this last month. I think it's because we're doing these regular topics every month, but we're definitely well into the 2,000 plus now. So thank you everyone downloading it. Rheumatology. I would like people in the room, and don't be embarrassed, just type something. No one's going to see this. How would you define rheumatology, people in the room? I mean, we're not going to tell you the answer yet. I just want to see you type in there. If somebody says, what is it? If a patient of yours said, what is rheumatology anyway? Catherine, Liz, Becky, what would you say to them? Oh, well, that's an interesting topic. I'll tell you tomorrow or something. But type, please.
Just Google. Just Google what rheumatology is.
Exactly. If you just like to lie down on the couch, we'll be back in a second. I'll get you a glass of water. In Google, which is fine. That's how it works. But yeah, it's not that obvious, is it? I mean, we were talking about this offhand, and Jack, you said, I'm not even sure I've got an answer.
It's very broad. Giving people the answer, isn't it? Very broad.
Is anything going to come in, people? Are you just bricking it already and thinking, I don't want to embarrass myself on social media? This is why I'm so pleased people download this and don't just join us live. No one's going to have a go. They're refusing. Not even Bailey's with a Y. 2 Y's has gone in there with. Oh, it's probably because they're all Googling it. Okay, this is not podcast entertainment. Right. Okay, so what do you think some of the interpretations of what rheumatology is? What have you heard maybe on courses, or your understanding what people think it is compared to what you would therefore say it is?
I think there's a few assumptions about what rheumatology is. I think a lot of people would just say it's looking after people with arthritis types, but then probably in some ways would forget or ignore osteoarthritis in that, which would be an odd one. So I think it's very heavily weighted towards arthritis. Mm-hmm. And I think that generally would be what it is. I think a lot of people assume that, or think that a lot of the diseases are very destructive to the joints and lead to a lot of disability and lead to lots of problems. So I think they think it's quite a severe type of issue to be dealt, if that makes sense. And a lot of people probably have no idea whatsoever. most people would say probably look after a rheumatoid arthritis or something similar like that, because it's in the name. But yeah, I think otherwise it is difficult because it, like as I said, it's so broad. So defining it is really a challenge to define sort of it as a specialty, really.
Okay, so it's a bit of a leading question, but I think it's probably one of those things of maybe what it's not, or realizing it's broader than what people might think. So what have we had here? Thank you, people who answered, by the way. Like I say, no one will know about it. Andy Glover has said it's a collection of inflammatory conditions. Okay, so the word inflammation's in there, so that's pretty broad. Catherine has expanded a little bit, an inflammatory response to the joints. Depends on what it is. Nice one, Catherine, leaving yourself open there. And then Liz Bailey has just bailed out. Do you like that pun? Liz Bailey's bailed out with, I've done Jack's course. It just wouldn't be fair. It wouldn't be fair, would it, Liz? No, it wouldn't be fair at all. So yeah, it does probably. I mean, what we're going to be talking about tonight is how a lot of people come into the clinic, particularly somebody who's offering massage, sports massage, deep tissue massage. Quite a large percentage of that population may well be suffering from some kind of rheumatic condition and not even know about it, and it may go undiagnosed for quite a long time. So talk to me a little bit about that. Why is it so easy for people to have something which needs diagnosing but they don't get to know about it for a while?
Yeah, and I suppose there's two answers to this question, really, and I'll just get a bit out of the way first. So some stuff that comes under rheumatology isn't coming into our clinics. It's not presenting with musculoskeletal problems. There are types of inflammatory disorder that affect the blood vessels and the skin, the lungs, and different bits and bobs like that. So, no one's coming in for a sports massage because their kidneys aren't working properly. That'd be really weird. Or if they had ulcers on their fingers, that would be really quite strange. But so we are going to talk mostly about the ones which have a musculoskeletal association to them. That's what I sort of specialize in, or try to specialize in. And that's the real problem, is they present with musculoskeletal symptoms. So if we take the two most sort of, or the ones that I talk about the most, which would be spondylitis and rheumatoid arthritis. So those two conditions, rheumatoid arthritis is going to present with joint pains, swelling, redness, maybe some stiffness, and spondylitis is going to present predominantly with back pain or tendon pain, or a combination of the two. And if we were to get people to write down how many patients today did they see who had either back pain or tendon pain, it's going to be quite a few of them. So we're taking all those patients that we see with those common issues, and then we're recognizing that underneath it's something else that's causing it. So let's take tendons, for example. Off air, you mentioned plantar fasciitis. It's pretty common. Someone starts a running program, their heel starts to hurt. We all see tons of those types of patients, but that could be the first presentation of something like psoriatic arthritis, for example. So it's presenting with that, and then then the sort of where the knowledge gaps are really is, what are the other signs, symptoms, features of those kinds of diseases that we're not assessing for, or we don't understand the association, let's say, with that. So for example, let's say we've got two patients. They've both got the exact same left heel pain, plantar fasciitis. They both started a running program 4 weeks ago. They're both the same age, both everything else is the same. But one of those patients has psoriasis. Then if you're not asking about skin conditions, then you may well miss that the second patient has psoriatic arthritis. They may not. They may have psoriasis and plantar fasciitis, which is load related. But if you're not asking, you don't know. And there are ways of doing that, and there are things that will increase the risk of them having that systemic inflammatory disorder versus just having a plantar fasciitis, for example. And it is complex. Rheumatologists exist for a reason. They only see these conditions, and even they get it wrong on occasion, and it is very challenging. They overlap a lot. It's very difficult to pin down, especially even when I was working in rheumatology and it was my job to differentially diagnose these patients. I'd still go to the rheumatologist 1 in 4, 1 in 5 times and go, I know it's a problem. I don't know which problem it is. And often it takes a few a few visits to work to really nail down what the specifics are. So it is a challenge and it is difficult. But I think as people who see mainly musculoskeletal issues, obviously I mostly talk to people, physiotherapists, osteopaths, chiropractors, especially these days in FCP roles, but also massage therapists, sports therapists. I would be saying, if those types of problems, if you're seeing back pain, tendon pain, we need to know other types of signs and symptoms that we need to look for, because if there are delays to diagnosis, we can come to talk about that later. But also your treatment's not going to work. So it's about knowing who to refer back out again. The equivalent, I call these conditions red flags. Hopefully everybody's familiar with a red flag condition. It's not cauda equina syndrome, it's not a fracture, it's not cancer, but it's not a musculoskeletal problem either. It needs medically managing when it's undiagnosed. So it's not for us as musculoskeletal type therapists to be dealing with in the early stages. They need to go to a rheumatologist in most cases.
Right, there's a lot there to unpack.
Sorry, that was a lot, wasn't it?
No, it's great, and there's so much there which is relevant to us. So so I like the way you said in your role, even you were going to kind of your superiors or to a rheumatologist. I know there's a problem here. I don't know what it is, but something's going on, because that's kind of what sports therapists, sports massage therapists, anybody who is allowing people to pay them for a solution to their pain or discomfort. You really need to be, like you say, you don't have to treat these things. It's outside of your scope of practice, but recognizing them. And that's been a common theme amongst all of our guests who work, for example, pelvic health, another big area which goes with lack of proper diagnosis for maybe 8-10 years. And although we're not going to treat some pelvic health disorder on men or women, just asking the right questions and sending them the right way. So rheumatology kind of fits into that, doesn't it? Mm-hmm. So also you mentioned psoriasis. Now, psoriasis is something which sports massage therapists are going to be super professional on, because they've got to think twice before they're rubbing somebody's arm and it's covered in something which looks a bit innocuous and kind of. So that's something which is taught a lot in sports massage, and knowing your contraindications and all that sort of stuff. And but I don't think, well, I know that on a course specification, there's not that link between psoriasis and some other kind of symptom, and definitely nobody would be aware of what you said it so beautifully, psoriatic arthritis would be. I mean, I don't think those two words come together. That's going to be new for a lot of people. Mm. So go back to kind of that person who came in. Let's imagine you know there's psoriasis, because that's going to be on your medical PAR-Q. That's going to be like, do you suffer from any skin complaints? Not for the right reasons, but you're going to be asking about that. What other things should you be looking out for, maybe be having on your PAR-Q to identify not just psoriasis, but psoriatic arthritis?
So I'm going to try and do this really quickly. So it takes me about an hour on my classes. So, so what you're looking for, and I apologize, I'm going to skate over some of this, but we're going to start to look for what I would call an inflammatory pattern to symptoms. So with inflammation, it causes a certain type of symptoms to be present. So we're often looking at symptoms that are worse in the morning, associated with joint stiffness or stiffness of the area, which tends to be worse in the morning, tends to take at least 30 minutes, if not an hour plus, to ease. So it's not, by the time I've walked downstairs, I feel better. It's really protracted. These people are getting to work before it's starting to ease off, for example. A really good response to anti-inflammatory medications. It will often wake them in the second half of the night. And had a patient last week, really specific. The guidelines, but the definition of inflammatory waking is between 2 and 3 a.m. And this lady said to me, I wake every night between 2 and 3 a.m. And I went, tick, off you go to a rheumatologist. But it's so waking in the second half of the night. So we'd often talk about night pain as a red flag, but this is very specific night pain. And they wake at 2 or 3 a.m. and they have to get out of bed to move around to ease that off. And the other thing is that it's better with activity and not improved by rest. So we think back to the plantar fasciitis patient that we talked about. How many plantar fasciitis patients do you see who improve when they go for a walk or improve when they go running, and their foot is not better when they raise it up on the couch? but that is flipped in something like psoriatic arthritis. So they like walking around, they like being in the gym, they like doing things. It keeps their foot much more mobile, it keeps the pain down, and then when they rest, they get a return of symptoms. So a combination of those symptoms are often present with psoriasis as well. So we're talking about cutaneous psoriasis that you mentioned. So psoriasis of the skin would be on the forms, but I am interested in cutaneous psoriasis, but if they've got psoriasis that affects their nails, then that makes it much more likely that they'll get an inflammatory arthritis. So what I would say to people is, someone comes in, they say they've got psoriasis and tendon pain, and they're seeing you for a tendon pain, then ask them about their nails and whether they get any changes in their nails. And there are good pictures on the internet. Just type in psoriatic nail into Google, and it shows you some good pictures of what you're looking at. But the nails become brittle, and they get stripy, and they break off from the nail bed. So it's things like that to increase it. There are also other associated inflammatory conditions, things like Crohn's, colitis, iritis and uveitis, which are inflammatory issues of the eye, and family history as well of inflammatory arthritis. But I think those things are important as well. But when you've got someone in, so let's say we've got that person in with the plantar fasciitis and the psoriasis, I want to know, okay, is this the first time you've had a problem with tendon? Because I think where we miss a lot of this, and this is not, I know this is not sports therapists, this is everybody, this is physios, GPs, orthopedics, you name it, we're all missing it, is that people are getting either recurrent tendon problems or they're getting multi-site tendon problems. And they're going from therapists to they're going getting some therapy, feel a bit better, go and get an injection, feel a bit better, they do whatever, they feel a bit better, and it waxes and wanes. But what you'll find is, if you have any of these patients, is I've got plantar fasciitis now, but 6 months ago I had tennis elbow. And 6 months before that, I had lateral hip pain. And they put it down every time. It's like, I started a new running thing. I moved house. I did this, that, and the other. And what you see is that they're getting these multiple sites. So I'm less concerned if they've had recurrent plantar fasciitis in the same foot. But if it's moving around the body, that's becoming more suspicious to me. So I steal this from Andrew Cuff. It's clinical reasoning seesaw. Stuff makes things more likely and less likely. And what I say is the psoriasis makes it more likely. If it happens more than once, it makes it more likely. But if it's happening at more joints, then it's more likely. And then if it's happening across more limbs, then it's more likely. So both feet versus both elbows, 1 foot, 1 elbow, you're bouncing around. So it's about, okay, I think what a lot of people do is they go, I've got this amount of time for my appointment. Oh, it's this barn door plantar fasciitis. They got heel pain, it got worse after they did some activity, and now it's really sore. They go, barn door plantar fasciitis, and then they stop because they've made their diagnosis in inverted commas, and they don't go, even if they asked about the psoriasis and they were like, oh well, it's only it's only one joint, it's not multiple joints. And they might even treat it and it might even get a bit better. But what they've missed is this 3, 4, 5, 6 history of other tendon problems in the past. And all you're doing is, in fact, are you even treating it, or did it just get better? And you've no idea. You've no idea whether it just got better, whether it was psoriatic arthritis or not, really. And it's certainly not down to me to make that diagnosis, not down to us. We need to get those kinds of patients to rheumatology, really, to make that definitive answer.
Brilliant. So yeah, once again, so much to note down there, people. I know the people in the room today, obviously they come here with their pens and paper. They've got little books called Sports Therapy Association Podcast, and they make chapters and things. They're really dedicated. But if you listen to the podcast, and that's the joy, you can stop and record these things because they're so important. Because as a sports massage therapist, whatever level you are, your teacher, your instructor is probably telling you, don't forget about the subjective, make sure you ask them questions, ask them enough questions and he'll tell you how to fix them. But it's still, I think, kind of just done, kind of going through the motions, because you can't wait to see if it's plantar fasciitis or see if it's this or that, because you're focusing always on basically ways you've been taught to cure kind of structural things. But like you say, looking at sleep, it's such a big thing. We learn on most courses, red flag. You mentioned red flags, but it's just the same old 5. which you're probably never going to see. Coward equine, you're probably not going to see cancer and stuff, and even pelvic health issues. It's probably more common, but serious stuff, I hope you do see them because you're going to make a massive difference. But so you get a bit lazy, but by asking the questions, are you actually sleeping properly? No, not really. Why? What's happening? And like you say, if they're waking up at a specific time, then that could well be linked to some kind of inflammatory condition. And the nails one was brilliant as well, and having a little conversation about anything else which is going on, or looking at your patient while they're talking and seeing. Real eye openers. And it really excites me because it gives. I champion the massage industry, not because I think massage is really effective. I mean, massage can help calm down the nervous system, and it can make people feel better. It gives people a chance to lie down and get away from life. But my biggest reason for championing the industry I started off is because they're going to come and see us first of all, probably. And they've got this relationship with us. If they allow you, if they disrobe in front of you and allow you to lay their hands on their back while they're face down with their head in a hole, then they probably trust you quite a lot, so you're going to get to see people whose lives you could change by pushing them in the right direction, and they're going to listen to you. So
I think with especially massage therapy as well, if you look at the research in rheumatology, the patients love it. So once you've been diagnosed, it's not a red flag anymore because you know what's going on, and they really enjoy it and find it really useful. To manage symptoms and pain and comfort and stiffness and this sort of thing. And I think if you're, I spoke to rival podcast, Matt Scarsbrook, and the massage.
He's no rival. He's just someone else who tries.
Just a pretender, And Matt, he made a really good point actually in massage therapy is if you've got the patient who comes into you and you say to them, look, I'm concerned that this might be what's going on. And it's not my job to differentiate that out, but I want to go and see your GP or whoever's most appropriate to do that, and just get it checked before we go any further. And then the patient goes and they have got psoriatic arthritis, for the sake of argument's sake. The trust they will have in you as a clinician, the odds of them not coming back to you is quite low. In my opinion, I think. Whereas with physiotherapists, for example, I can't do massage to save my life. So exercise is I have one tool, it's a hammer, and it's exercise. And if it doesn't work, I've got nothing really. And I just don't think it works so well. But I think with the long-term conditions, especially, I think, like you said, I think you can make a big difference to these people with regards to their symptom management. And if they have that trust, whereas if you were to say, let's flip it and say, you try and treat them for 4 or 5 sessions, nothing happens or it's deteriorating. And then suddenly they're like, oh, it was getting worse. I went to my GP and now they think I've got this arthritis and you missed it. I'm being harsh, but they're never coming back after that. Do you know what I mean? And I think, like you said, that spending that time to understand the questions and what you're asking questions for. And I think that's really key. There was a conversation on social media the other day about prior health screening, and it's understanding why you're asking specific questions. And I said, absolutely, psoriasis, if you're going to rub the area, but understanding why other reasons why you might be asking about psoriasis or pelvic health or X, Y, and Z or gut issues. There's a couple of questions about gut issues. Why are you asking that question? And what does it mean in the context of the symptoms they're presenting? And it's hard. I'm not gonna, I worked in rheumatology for the best part of a decade, then carried on teaching, and I still learning tons of stuff. I was on a webinar before we came on here, learning about bloods. It's not easy. It's complex, but trying to learn a little bit, especially if we're just talking now. If you are a lower limb specialist, for example, then looking at things like psoriatic arthritis, gout, etc., is going to be really helpful. You can narrow that down a little bit. If you mostly see backs, looking at ankylosing spondylitis, axial SpA, those kinds of conditions, going to really help. And trying to learn as much as you can, really. And I know probably your other guests have been saying the similar thing. Try and learn as much as you can about my specialty. Learn as much as you can about my specialty. So it is, you get pulled all over the place. I only have to learn one thing. I'm okay.
Yeah, it's definitely. And the other thing, like you said, patient's going to really respect you, and they're probably going to come back to you. And also the other thing is there's I did go through a stage where I was worried because I was basically telling people how to have less patience. It felt like, if they don't need to come back, don't say that they need to come back for 8 sessions. It's just not ethical and blah, blah, blah. And the kind of traditional business model failed because it was like many companies base it on the idea every patient we see 6 times, make an average of this and we can pay this and blah, blah, blah. But you can't do it like that because you're not treating the individual. But the new business model, and when we do a focus on business as part of the Sports Therapy Association podcast, I'm not sure what month it'll be, but we will do a focus on business because it is a business. This new part of forming a real important part of a chain in healthcare where you're talking the same language as the rheumatologist, as the GP, as these people you're referring out to, as the pelvic health specialist. If they know that you're on the same page, they're going to start sending people your way for massage, sports therapy, maybe some exercise prescription of some form, because whilst they're hearing that, this massage therapist was breaking down knots in my hamstrings the other day, and they're not going to they don't consider you as, this is why we're not allied health professionals. We're not even health professionals, not even allowed to use the word diagnosed, because there's a lot of rubbish which is traditionally kind of taught. But if you're sending people out saying, I suspect there's maybe a rheumatologic condition going on here because of blah, 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 bam, that person you're referring to is really going to respect you. And you're going to be the little fish in a big pool. You're going to be the one who they can then send people back to you. So good business model, which is important to remember. Right, we've got a few questions, which is lovely to see. So if it's all right with you, Jack, let's just scan back a bit in the comments. Remember, if you listen to the podcast, do join us live 8 o'clock UK time. You can ask questions to our guests. Let's have a little look. Becky Carroll says, I'll bring it up on the screen as well. I think I'm right in saying that RA is generally diagnosed if your markers are higher than 20, ? Is it possible to be around the 15 to 18 level and yet still be symptomatic of RA?
I'm going to make some guesses here, Becky. So I'm guessing that you're talking about inflammatory markers. So the inflammatory markers can be normal and still have rheumatoid arthritis. There's also more specific markers. So there's an autoantibody. So an autoantibody is an antibody directed against the self. So it's not directed at COVID or whatever other illnesses you might come into contact with. It's directed against your tissue. So the one in rheumatoid arthritis is anti-CCP. And so that either comes back positive or negative, but will come back higher or lower. But that's a lot higher than 15 to 18. So I'm guessing it's CRP and ESR that she's mentioning. So it's more around the symptoms that are presenting. And this is what makes it complex. So you can have some patients who have big, red, hot, swollen, stiff joints, both hands, both feet, both knees, both ankles affected, but their ESR and CRP levels are normal. So as Becky says, below 20. And then other patients that don't have anywhere near those symptoms, they've just got maybe there's a little bit of a stiff hand, and it turns out their CRP is 100 and their ESR is 80. So it's more to do with what the symptoms are, and that's what makes it a lot of complexity. So I wouldn't be overly concerned about the blood results, in all honesty. I'm concerned about them if I'm working in rheumatology specifically. The rheumatologist be concerned about them. In MSK, I wouldn't be. I'd go with symptoms, really.
There you go, Becky. Come back if you need a follow-up to that. Catherine Reimer, happy birthday again, Catherine, has asked, are there links to IBS and other bowel issues that relate to rheumatoid arthritis?
Okay, so 2 parts again. So IBS is a really difficult one. IBS, as in irritable bowel syndrome, doesn't link to inflammatory conditions. As far as I understand it, it's not inflammatory in nature in the same way that Crohn's and colitis are. So that's ulcerative colitis and Crohn's disease. However, if IBS has not been investigated, then there's always a little bit in the back of my mind as going, I'm not a gastroenterologist. I've said a lot of things I'm not. I'm not a gastroenterologist. Who am I to say that IBS isn't Crohn's disease or colitis? So I would be a little bit, unless if it's been investigated by gastroenterology and they're like, yes, it's IBS, it's none of those other things, then I would discount it. The other thing is, we get into complexity again. The gut issues are not necessarily related to rheumatoid arthritis. So Crohn's and colitis, you're much more likely to get the spondyloarthritis issues. So you're much more likely to get ankylosing spondylitis or the psoriatic arthritis type diseases, not rheumatoid arthritis. However, everybody's a unique individual, and there will be some patients who have Crohn's or colitis and rheumatoid arthritis. So if they have another inflammatory disease, they are more likely to get another inflammatory disease, but it's not the true link like it is with the spondyloarthritis. But we're getting a bit technical there.
Great answer, Catherine. If that's got any follow-ups to that, Catherine, then obviously let's fire another question our way. Becky's back again. Becky was interested to know, she says, sorry, me again. Don't apologize, Becky. Fire away. Why is the magic time 2 to 3 o'clock?
Yeah, great question. So when you go to sleep, your body systems take a rest, much like the rest of you, and so does your inflammatory system. And then around 2 or 3 a.m. it kicks back in again, ready to protect you from the world the next day. So patients tend to have no symptoms up until 2 or 3 a.m. The inflammatory system kicks back in again, starts reacting against what it's reacting against, and all of a sudden you realize, oh my God, my hands really hurt or my back really hurts, and it wakes you up out of your sleep, and you're like, ah. And then you want to do something about it.
There you go. It's worth watching the live show just to get the facial expressions and the kind of like hand gestures which are happening tonight.
And also, this is really good for anybody listening back, but I hope everybody's noticing my Hogwarts, which Matt laughed at.
I didn't laugh at it.
And if you want to be really specific, that is just the astronomy tower, and I have to get the Great Hall to attach to it yet. It's a 3D puzzle. I have nothing better to do with my time.
We should mention at this point and congratulate this geek here that he's actually got a 4-week-old baby. Congratulations, Jack. There we go. We have some R's and congratulations in the comments coming in, I'm sure. 4 weeks. Oh, look at that. Well done, mate. Congratulations. Catherine Ryan has come back here with I find rest does make my costochondritis worse, linked, I think, to my RA. Movement does help and doesn't stop me lifting weights.
Very common. Yeah, very common. Yeah, so really surprised. You'd be really surprised. People come in, they'll sit in your waiting room and they'll get up and they'll be like, really stiff. They can't move anything. And you're like, oh, how do you do anything? They're like, oh, I'm fine in the gym. Lifting weights, deadlifting, running, all this sort of stuff. It's only when I sit down that it's really bad. Then you're like, bing, that's rheumatology.
Explain costochondritis for people who may be listening who aren't quite sure what that long word means.
It's inflammation of the joint between your rib and your sternum or spine.
Causes? Or is that
causes the inflammatory arthritis. What a lot of people would probably call a sprained rib from coughing can often be costochondritis. So you cough a lot and then you get an inflammatory reaction around the rib. It does occasionally occur on its own. It's an awful condition. Nothing really works to change it. Sometimes a little bit of mobilization can help, but just as many times makes it ton worse. Horrible condition. Yeah, really, really difficult to manage.
Thanks, Catherine, for sharing that. Let's have a little look. Andy Glover comes back to answer a question to Becky. This is a lovely thing about joining us live. You can answer your own questions with each other inside the room.
Yeah,
Andy Glover said, I believe the immune system becomes very active at that time. Happy to be wrong.
Yep, very good answer.
So there we go. Liz Bailey has asked or stated, I'm sure I missed inflammatory back pain in a young guy with bilateral AT pain years ago, an inflammatory PF in someone else. Only realized once I'd done Jack's course. Annoyingly, it's really good.
Checks in the post, Liz.
Yeah, I mean, so just to mention Jack's course, thanks Liz for bringing it up. But yeah, so Jack, you have got, I mean, first of all, people who aren't aware, my guests I've had throughout this month of Focus on CPD have got fantastic websites where you guys are just giving away such valuable information, and yours is no exception to it. Let me just bring that up in a little picture there. Sorry, Liz, your comment's going to disappear for a sec. So yeah, if you head along to rheumatology.physio, clever website name that is. It's not like .co.uk or anything. No. It's rheumatology.physio. And you'll find obviously details about Jack's courses, which if you're listening to the podcast, just because you can't see the screen, we've got, let's have a little check here, my crib sheet. So online, there's Recognising Rheumatology, a half day on the 12th of April. In Birmingham, there's Recognising Rheumatology, which is a full day because it's face-to-face, and that's on the 7th of May. And then in Exeter, on the 9th of July, you've got another face-to-face full day, Recognising Rheumatology. And all of these courses are accredited and recognised by Liz Bailey, dance physio extraordinaire. So if you've got any problems with them, just take it out with her. Bayley, just in case you don't want to make her mad about that. So yeah, but as well on the website, you've got a fantastic blog. You've got resources. You've got all sorts of things. Some of them are pay, obviously, but some of them are free, and it gives you a good insight into what the whole thing is about. Lovely website there. And at the bottom, you can see what a nice bloke Jack is. It's like website front page. Hi, I'm Jack March. Beautiful. It's great. So, and also before I forget, mate, you've also got the audio book, haven't you? Downloadable.
Yeah, there's an audio. You name it. I've done a few things. I've got books, audio book. The audio book's funny because I think it's got really, really good content in it. However, when I recorded it, I didn't really know what I was doing. So you're just basically listening to my voice be quite slow.
Really selling it here. Yeah, go
on. I know,
then.
but the content's great. So you just have to put, like, I think ideally you'd put it on like 1.4 times speed or something like that. And I think it's going to be really, really good.
Okay, well, there you go. But yeah, loads of resources there. And again, whenever people are saying all these conversations on social media, what CPD should I do? And you like got this burning desire to spend £500-600 somewhere on a course. There's some amazing courses out there, like Recognising Rheumatology 1-day course or half-day online. But take advantage of the free stuff which these guys put out as well, you know, and things, even things like this, just coming on this week. It's such a great way to learn things from different specialists. So yeah, rheumatology.physio. Anyway, let's get rid of that for the moment. Let's see if we got some more questions from the live lounge here. Leslie Campbell. Jack, I mostly get lower back pain clients. Which of your books is best for me to have?
Oh, Leslie, I'll give you a tip as well. I'll tell you what, look, what have I got here? Here we go. Look, so I do some little books like this. Oh, it's gonna be backwards on the webcam, but I do 4 or 5 of these. I can't remember now, but I've got one which is rheumatology. I'm gonna be naughty and show you the AXPAR page, although it's backwards, so it should be good. But basically, it gives you the symptoms, what to suspect of an axial spondyloarthritis. 10 conditions in there. We've also just done with Adam Dobson. We've done some. We did radicular syndromes for the low back, and then the other one, which I think is my favourite actually. And all I've got is the one that I mistakenly messed up with printing, but. This is a clinical scenarios book, right? So this is available as an ebook. You can't get it hard print because what you'll notice if you're really clever is I printed it back to front. So the thank you is the front page, which is really stupid. But so it goes thank you and then preface.
Was that like just a little spin or something new, or was it just a genuine mistake?
I just totally messed up the formatting of the front page. So it's just bad. So it's completely useless.
It's nice though. No, it works nicely. Yeah. Thank you. Start off with a direct address.
But that's my favorite one because I wrote it and it's got about 16 clinical scenarios in it. So what it does is it takes you through how the patient's presenting. So we talked about asking questions. It gives you some of the subjective information that they're presenting with, and then what it does is it says, what would you think might be the problem, and then what I've done is underneath I've written this could indicate this and you should do this with it. And I really like that one. It's my personal favorite one, and I think for some reason it's the cheapest one as an ebook as well. It's like £5 or something ridiculous,
maybe because of the printing. Yeah,
well, that's maybe. But yeah, I really like those. But yeah, the rheumatology one is good, and then that clinical scenarios one's the best one, I think.
Let's thank you for a great question, Leslie, and keep the questions coming. It's great, people. Thank you very much. We're coming kind of closer to the bewitching hour of 9 o'clock and the end of the show, but so people are coming in. You mentioned a few ways which you can ask the right questions, concentrate on the subjective, refer to a rheumatology specialist if you're not sure about it. What about when you do refer people on, because it's nice to know if you are referring people on, what sort of attention are they going to get then? Is there, we know there's a lack of diagnosis and people can suffer unnecessarily, but what kind of solutions are there if they do go on and reach that specialist kind of care? What sort of, how can they improve their quality of life?
Yeah, so it's really good these days. So certainly I started in rheumatology 2011. No, I don't look that old, Matt. You're right.
Miles away.
And that was when the newer medications were just starting to take hold, really. And certainly over that period of time, it's got really good. They started new treatment regimes. So certainly the last 5 to 10 years or so, the aim is to get people back to full function and no disease at all, or no symptoms. So really good, especially the earlier you pick them up, the better their outcomes are going to be, the less medications they need, all those sorts of things. But yeah, they do very, very well these days. So taking your question ever so slightly further, I would say, if I suspect these conditions, I'll say something like, I'll be quite specific because I'm nerdy and I'd like to be like that, but you might not want to be quite so specific and be held to things. But I'll say, I think you might have psoriatic arthritis, or these symptoms lead me to believe that might be what's causing these symptoms. And what I want to do is get you further investigated to rule in or rule out more the likelihood of that. And we're going to do that by wherever. It might be via the GP in the first instance. It might be a private rheumatologist. It might be, if you're in a referring role, straight to rheumatology. We're going to do that, and that'll involve probably some blood tests, maybe some x-rays, maybe an MRI. I'm not sure. That's not my job to do the investigations, but they'll do a thorough workup and work out whether this is causing it or something very similar is causing the problem. Hopefully it isn't, in which case, great, we'll treat it. If it is, they'll tell you what the next steps are. It usually involves medications. They are extremely effective, and I would expect that you would get back to all your hobbies, all your work, ideally 0 symptoms whatsoever. And how that course takes is very individual, but hopefully that's where you'll get to. And usually I find, sometimes it take a little bit longer than that to say those things, but usually I find that reassures most people that's
great to hear. That's great to hear. So even though it gets missed a lot and people go through unnecessary kind of pain for a long, long time, if they do get referred on, thanks to maybe you, then I'm talking about the audience listening to this, then you could sort them out and change the quality of life pretty quickly. That's good to hear. I just thought as well, do you by any chance, this isn't a leading question, I really have no idea to the answer to this, but a few of the other guests we've talked about, like pelvic health with Emma and Grenier, for example, are producing are producing infograms. Have you got involved in that little plastified, laminated sort of things that soft tissue therapists could have in their clinic to show patients what they're talking about when they say, look, I've noticed you said this and that? Because that gives, I think, sometimes therapists a bit of confidence to have posters and things up. Is that something you've thought about?
I have, and the little booklet I showed you started off like that. And what I did, because of the overlapping nature, it was unusable mess, and it turned into the book eventually. I'm not an artistic person, so it's not my area of expertise to do those kinds of things. I have seen some flow charts for spondylitis and rheumatoid arthritis. There are also some scoring algorithms that can be used. So find this on my website as well, which could give some graphs. So for osteoporosis, for example, gives you a risk graph. Axial spondyloarthritis and psoriatic arthritis, you can get a risk graph. So you can tick the boxes and it will say, this is what we should do. So there are a few things like that. But no, I haven't made anything like that. But
that's okay.
Each time I try and do it, it gets so complicated, I stop doing it.
But maybe maybe just a copy of your books would probably cover quite a lot of it, but just having that backup, so you're not having to remember yourself as somebody who's doesn't know anything about it, just be able to flick through the pages and just read things and kind of fake it until you are that familiar with it, just to have that confidence.
That's what I do. I use my books. Yeah.
Of course you got to. And also, hopefully it's a common theme. I like to think that clinics, and people who've joined us live, let me know, but the new style clinic, as opposed to having kind of like things which could cause catastrophization and stuff, like kind of like menisci separated from the knee and kind of lying down, or big kind of spines with red dots and donuts and things. If you can have nice, modern, kind of friendly to see explanations in diagram form of what's going on, they could be really useful around your clinic, especially in kind of the waiting area and stuff, and create that impression and that truth that you are part of a chain of healthcare. You're not going to cure these things, but you know about them, you're looking out for them, and you refer on if necessary. I think that'd be really cool to do, people. You're just not going to get them from Jack, but they are out there. Cool. Okay. 9 o'clock, mate. I just want to quickly, I don't want to let you go before. Is there any other specific, you don't have to go into what causes them too much, or what other conditions do you think people might be walking through our door as soft tissue therapists, which we should maybe read into and know a little bit more about?
So we've talked about psoriatic arthritis. It's that would tend to present mostly in the periphery, so hands and feet and elbows and knees. Axial spondyloarthritis is its like spinal cousin, like spinal friend. So similar sort of presentation in the spine and the buttocks. Then I would be, I mentioned this just before, and I'm glad you've reminded me, but polymyalgia rheumatica, which presents with quite diffuse upper trunk, shoulder, girdle type pain. I can really imagine that someone who wakes up with early days polymyalgia rheumatica is going, oh, my shoulders and back are really stiff and achy. I really want a massage. Like, I really think that that's a prime thing that might come in. There's a really good podcast with me, but with a great guest. That's been probably my most popular podcast on polymyalgia rheumatica. So that's on the website. It's also on YouTube channel. Just type rheumatology physio in wherever, and I do come up. But I'd say polymyalgia rheumatica actually is probably quite high, and people may not have heard of it or don't know what it is. But I think for massage specifically, I think people are potentially going to come in. I think less likely with things like rheumatoid arthritis, because they're angry, red hot joints in the fingers and feet, and I think people do tend to go to the GP because of the angry nature of it, more likely than that. But that should cover, I say on my courses, I go into some other diseases and things, lupus and Sjogren's syndrome, connective tissue disorders, but to be honest, they're less common. And as long as you're aware of inflammatory type patterns, like we talked about, the associated inflammatory diseases that make those more likely, then they're still going to trigger your thought process for this might be inflammatory and I should get this investigated. Lots and lots of joints involved, or widespread, or arms and legs. I'm always interested in those kinds of things. You'll be pretty close.
Fantastic. There we go. So if this is kind of sparked your interest in being able to help the many people who are probably walking through your door and may need referring to a rheumatoid specialist of some form, then Jack's courses, like we say, are happening in a city near you in the not too distant future. So we got the online version, which is 12th of April, and then in Birmingham, 7th of May, full day, face-to-face, and then Exeter, 9th of July. We'll make sure that they will go into the show notes as well.
I think I'm going to Belgium as well, if anybody wants to come to Belgium. I can
see that on your website. Okay.
I don't think I've managed to get it on. I think it's in October. If anybody wants to come and have a what are they, a leffe? Have a leffe and talk about lupus.
Exclusively, bombshell on the Sports Therapy Association podcast. Matt Scarsbrook didn't get that sort of revelation. So first hearing it here, Belgium date, which will go onto the website very shortly. Right, amazing, Jack. Thank you so much for joining us. And thank you for joining us, people. Catherine Reimer says, interesting discussion. Thanks, Jack and Matt. Thank you very much. Phil Griffiths has said, thank you, Matt and Jack. Really informative. Thanks for including me in this, guys. Becky Carroll says, thank Jack and Matt. Very nice. But thank you, people, for joining us live. And if you listen to the podcast, thank you very much as well. Do try and leave a review and a rating if you've enjoyed the podcast, because it just helps the information which our fantastic guests give for free to appear higher up in Google. And that's what it's all about. It's about disseminating this information and letting people know. So, Jack, if you'd be so kind to hang around, just so I can say thank you personally. Everybody else, we'll be back next Tuesday we've got a new topic. Of course we have, because it's April. And April is going to be, you might have seen it advertised on my social media, but we're going to be doing Sleep Awareness Month. It's all about sleep. And it's a huge thing. We mentioned sleep tonight, asking the questions about how's your sleep. Straight away with that question, potentially, if they're talking about waking up at a specific time, then that could be linked to a rheumatologic condition. But there's plenty more about sleep, which anyone who follows me on Run Chat Live has been kind of listening to probably. I did a sleep study myself for 5 weeks where I was hooked up with a in-home polysomnogram system, measuring brain waves, measuring the different stages of sleep, rapid eye movement, all these sort of things, with the wonderful people in Canada in a company called Cerebra. So the results to my 5-week in-home polysomnogram are going to be revealed at the end of April with Amy Bender, Dr. Amy Bender, who's the Director of Clinical Sleep at Cerebra. But before that happens in April, we're going to start off with Jessie Cook. I'm really looking forward to chatting to. Seems like a really interesting, passionate guy, so passionate about sleep. And he's going to be opening up the show, or the month rather, with Sleep, the Silent Epidemic, which sounds like a little bit of clickbait, but I urge you to check in with this episode in particular, because it'll open the whole thing about why we're having like National Sleep Months, why I'm so interested in sleep now, rather not just about my own personal struggles I've had with insomnia and stuff, but just across the nation in the healthcare system. It's going to be growing. It's going to become more apparent of what a foundation kind of it is to everything else. If you're not getting either good quality or quantity. So I urge you, if you listen to the podcast or joining us live, to check that out. Part 2 will be the second week of April with Dr. Olivia Walsh, talking specifically about sleep trackers. Quite a few of you using kind of Fitbits and Oura rings and kind of other kind of wearables, which vary from, you're going to hear basically about how much they are helping you, how accurate they are, how useful they are. And there might be a few surprises there. So tune in for that. The third week is going to be with Dr. Jonathan Charest, talking about specific for injury and performance, about how sleep is related to that and how you need to be having these conversations with your athletes or recreational athletes. And then, like I say, we'll finish off in the fourth week of April with Dr. Amy M. Bender, who by then will have analysed 35 nights. Actually, it's not 35 nights, it's about 32, because I've got this, I have this kind of technical word for it is somnambulation, where I move in my sleep, and it's a trait I've had since birth, I think. But you're like this, Jack. My wife wakes me up because I'm lying there in bed, I'm fast asleep, but my arm is up in the air, and I'm just stroking my arm up and down whilst I'm fast asleep. I'm just basically a self-stroker while I sleep. So we'll be talking to Dr. Amy Bender about that, and different kind of sleep disorders. At the end of April. So there we go. But until then, do please download the podcasts. There's so many episodes there. I'd just like to say thank you once again to Jack March for joining us. Thank you, Jack.
Pleasure.
And we'll see you all next week, Tuesday at 8 o'clock, which is GMT +1 if you're listening from outside the UK. Right, take care, people, and we'll see you then.